Good morning, my name is Darren Chandler, educator with North West Ambulance Service. I'm here with Richard Whiteley. Could you introduce yourself, Richard?
My name is Richard Whiteley, based at District Ambulance Station, McKinn's 52138.
And Richard is doing an assessment this morning for CT15. It's the primary secondary survey. This is part one of 3 uploads. This is the actual primary secondary survey. The second upload will be the recovery position, and the third will be the professional discussion. And so regarding this aspect of the assessment, Richard, are you happy? You understand what's expected?
Yeah.
And you feel you've had enough practice?
Yes.
And you don't feel unwell in any way that might hinder your process?
No.
Okay, so you're on an ambulance and you're working as part of a double EMT1 crew, and a job comes through to your screen, and it's a 45-year-old male by the name of Rhys Evans. So 45, Rhys Evans. Rhys has been found by his neighbour to be collapsed on the kitchen floor, and the neighbour has rang 999 but didn't have any details to give. They didn't know much about him other than he was a neighbour, but they knew his name. The neighbour couldn't stay and won't be there when you arrive.
Yeah.
Okay, so when you're ready, you can start whenever you feel ready.
Okay. So I'm going to approach the scene. I'm going to be looking for any obvious dangers, cables, trips, slips, fall, anything slippery on the fall, any noxious gases, anything like that. I'm going to note the number of patients. If there's 3 or more patients and I have no obvious reason for illness, I'm going to consider withdrawing from the scene and asking for specialist help. As I approach the patient, I'm going to note anything abnormal. I'm looking for catastrophic blood loss. I'm looking for any obvious signs of injury that's been caused to the patient. There might be a brick lying next to him. He might have a head injury. I'm looking at his limbs, looking for any obvious breaks or fractures. I'm going to approach the patient. I'm going to announce who I am. Hello, my name is Richard. I'm with the ambulance service. Can you hear me? Rhys, can you hear me? Rhys? Rhys?
It doesn't respond to your voice.
Okay. No, guys, I'm going to try pain response by squeezing the trapezius, I think it's called.
And he doesn't respond.
No response there. I'm now going to call for paramedic backup and ensure that's on the way. I'm now going to check the patient's airway. I'm looking for any obstructions. Might be liquid, solid, blood, might be some swelling. If I find anything in there, I'll consider removing them with McGill's forceps or suction. And after checking the patient's C-spine, I might consider using a postural drain to drain any fluids out. I'm now going to check the patient's C-spine for any obvious abnormalities prior to carrying out a head tilt and chin lift. I'm now just going to quickly check around the patient's neck and throat for any signs of swelling. Okay, right. That's my fast primary out of the way. I'm now going to, sorry it isn't, I'm now going to check the patient's breathing and respiration. So I'm just going to check the patient's breathing and carotid pulse.
And you find the patient is breathing, you can see the chest rise and fall, and you can feel breath and you can hear breath, and you can also feel a pulse.
If there was no pulse and the patient wasn't breathing, I would commence CPR. I'm now going to commence the full primary. So I'm going back to the patient's airway. I'm looking for any more obstruction, anything in there, vomit, blood, swelling, anything like that.
Nothing's appeared.
Nothing's appeared. I'm now going to insert the nasal. I'm looking to secure the patient's airway, the esophageal bit under the sides, front teeth to the lower jaw. I'm going to insert, rotate, locate, and I'm observing for any gagging that might occur.
There's no gagging.
I'm going to size the appropriate nasal tubes, which from the ear through to the nostril, which I'm going to lubricate. The short end I'm going to place next to the inside the patient's nose. I'll insert that, and again in the middle of the ear, the tragus, the nostril, and short end, in it goes. I'll secure the patient's airway. We'll check the patient's breathing now. Looking for respiration.
The patient is still breathing and the rest rate is 14 a minute.
14 a minute, yeah. I'm also listening for any noises, any wheezing, whistling or silence. If the patient's respirations are less than 10, I would consider a bag valve mask to assist with breathing. I'm going to check the patient's oxygen level using the SAS probe.
That's 96%.
Okay. If the patient's oxygen level is less than 94%, I would consider the use of supplementary oxygen. I'm going to move on to the patient's circulation. I'm going to consider the patient might be bleeding somewhere, so I'm looking for blood on the floor. And 4 more. So I'm going to check the patient's chest, looking for any swelling, any bleeding, any bruising. Move down to the pelvis. Not moving the pelvis if I can help it. Looking down, looking for any signs of bleeding, bruising, exposed legs. I'll cut the trousers if I needed to, using shears. I'm going to check the patient's capillary refill.
And that's less than 2 seconds.
That's on the forehead as well.
It's also less than 2 seconds.
I'm going to check the patient's pulse in each arm, looking for a strong, regular pulse.
And so that gives you a rate of 65. They do match and they are strong and regular.
It's a normal pulse rate for the patient. Now I'm going to take the patient's blood pressure. I'm going to do that in both arms.
And that's 120/80 both arms.
Which is perfect. Freakishly perfect. So I've checked the patient for any signs of bleeding, I've checked the capillary rate, I've checked the pulse, and I've checked his blood pressure. Now I'm going to move on to the disability section. So again, I'm going to check the patient's level of consciousness. Hello, Reese. Reese, can you hear me?
Doesn't respond.
Doesn't respond. I'm going to check the patient's pupillary reactions.
And when you look, they respond to the light and they are 3 millimeters in diameter.
I'm going to check the patient's temperature.
That's 36.7.
Ideal temperature. I'm going to check the patient's blood sugars using a BM.
That's 5.4.
Again, that's well within range. I'm going to calculate the patient's GCS score.
And that's 3.
That 3 is because the patient's unconscious. I've exposed the patient's chest. I might consider using a 4-lead ECG at this time. Moving on to E, I'm going to expose and evaluate the patient. So I'm just going to open up the shirt, have a quick look for any other injuries that might need attention. I'm going to treat those as needed. Again, looking at the legs, if I need to cut the trousers to remove them, I will. I will consider the patient's dignity at this point. Is it cold? Have we started gathering a crowd? I will cover the patient as needed at this time, and if there was a crowd, I will try and arrange some screens or potentially move the patient into the ambulance to continue the rest of the assessment. If the patient was showing signs of cold, hypothermia, I would cover the patient and get him to a place where he's going to be warm. If it's cold outside, we're okay, Dave, I think. I'm going to move on now to my secondary survey. So again, I'm just checking that the patient's breathing and circulation using the blood sat sensor. I'm going to start at the patient's head. I'm looking for any swelling, indentation, bleeding, anything out of the ordinary that might indicate an injury. I'm checking the patient's ears for blood or yellow fluid that might indicate a spinal injury. Checking the patient's eyes round the eye socket. Looking for any bruising. Checking the patient's nose around the mouth. And looking for any false teeth, anything that I can remove. It won't hurt. I'll have a little look in the airway, make sure everything's okay there. Checking the patient's chin and down to the patient's neck. Looking for any Medi-Alert necklaces, any obvious signs of injury. I'm going to check the patient's airway again, make sure they're still breathing. I'm now going to move down to the patient's chest. I'm exposing the patient's chest, and again I'm just looking for any major signs of swelling, any ribs poking out, anything out of the ordinary. Checking the patient's skin temperature, the colour of his skin, looking for anything abnormal. I'm going to listen to the patient's chest, listening for any wheezing, crackling, bubbling, whistling or silence. I start at the top and work my way down. Listening to each part of the patient's chest. Laterals. Now I'm going to move on to, I'm going to check the patient's airway again, make sure we're still breathing. Now moving down to the patient's abdomen. I'm looking for any swelling. I'm looking for a patient's reaction to me pressing into his abdomen, looking for anything, looking for any signs of pain. And I'm feeling for any swelling, abnormality, anything that might indicate an injury. Again, I'm going to check that my patient's breathing and he has a circulation. Moving down to the pelvis, I'm just carefully not wishing to move the pelvis too much. I don't want to move a blood clot. Feeling for evenness, make sure there's no pelvic injury. I'm noting if the patient's wet himself or if he's soiled himself. He might potentially even have an erection, which might indicate a neurological problem. I'm checking my patient's airway again, making sure that he's breathing and he has a circulation. I'm going to expose the legs properly if I haven't already done so. I'm moving down the legs, looking for any swelling, bruising, anything that might cause me concern, noting the temperature. Any bones poking out. Moving down the leg. I'm noting if there's any radio location beacons on the leg that the prisoner might have that might affect an ECG later. Moving down to the feet and checking for a pedal pulse. I'm looking for any injuries to the feet, capillaries. I've got the mention on the chest. I might be looking for a pacemaker or anything else that's maybe fitted that might give us a clue to his medical history. Checking the patient's airway and breathing. And moving down the arms. I'm looking for any injuries, any bones poking out, track marks, medialate bracelets. Moving down, checking the fingers again, any track marks. Okay. I'm going to cover my patient again. I'll tell you what I can do. I could consider at this point a 12 lead ECG, which is on the patient's chest. I'm checking my patient's breathing and circulation's good. I'm awaiting paramedic arrival, so I'm now going to place my patient into recovery position, which is going to help maintain his airway, draining the fluids.
Due to the nature of this mannequin, he won't go into the recovery position. That's in the second upload that I think you've already done, and that'll be in addition to this one. So let's assume that he's in recovery position.
So I'm going to check the patient's back and posterior for any injuries, noting anything that might indicate any further injury. Whilst in the recovery position, I'm going to rotate the patient every 20 minutes. To the other side if needed. I'm going to continue taking observations every 15 minutes, but I'm constantly going to be assessing that the patient is still breathing and any other circulation. On paramedic arrival.
And so, yes, your paramedic arrives. Hey Richard, I'm Darren, and could you give me a handover please in the form of an escort?
Yeah, so the situation is we have a 45-year-old male, Reece Evans. He was found by a neighbour on the kitchen floor in this position. So he was lying on his back, supine when I got here. We don't have any details of the patient. The neighbour's left. He hasn't provided us any details within the medical history or anything like that. We have nothing to indicate what has happened to the patient. My assessment is that the patient is unconscious. All other observations are within range and normal. That I know of, there might not be for this patient, and my recommendation, so I carried full primary, full secondary, found no injuries. My recommendation is for you to carry on an assessment and possibly move the patient to hospital.
Okay, thank you very much. And I might have missed it, but let's imagine it took me a little bit of time for me to get here. Is there anything you could be doing with the information that you've found?
I could be uploading the information onto my PRF, patient report form. That is available for the people to read. I'll make sure that information is accurate, it's legible and it's timed, so that the person will see how old that information is. As I say, I'll keep updating that PRF every 15 minutes, looking for signs of improvement or deterioration for the patient.
Okay, thank you. Right, so I've no further questions for you, just feedback. It's a pass, Richard. It's a pass.
Thank you.
And so, in terms of all the good points, you systematically went through it, and so in particular the early points, you nearly missed, I think, doing an airway check. You were going to move on, but you got it. You said, I'm going to move on, but oh no, I'm not. I'm going to.
Yeah.
So you completed it. You remembered, which was good. So from a danger point of view, you considered safeties. You noted your patient, and you found the patient to be unresponsive, and then you treated that with your scope practice and shouted for backup, which is good. Then you went through the ABC approach and managed that correctly, and you secured it too. I really like your continual regular checks because people can deteriorate, and that's a really, really good thing. From your ABCDE approach of your assessment, you pretty much got all the observations that you needed. Sometimes with your assessments you're a little bit disjointed, you did kind of move around back and forth, which looked a little confusing because it's kind of indicating you'd forgot it, but the point is you remembered and you came back and you did it. And so when you did further assessments you also repeated it, so you were double checking, reassessing and looking for further things. So good, thank you very much.
Brilliant.
A little bit of practice more. It's still early days, isn't it? It's your first OSCE,
Yeah.
and I can tell you were nervous. I could see, and so hopefully you get an idea of how these work. Yeah, and don't feel as nervous. Fingers crossed. Hopefully not. Right, so turning the recording off. 10:05.